Good evening and welcome to Best of the Day from the 55th annual meeting of the American Society of Hematology. We're meeting in New Orleans this year, which is very much decorated for the holidays, but the weather has been sort of cool and damp and at times rainy, but we're all getting along fine. It's been another interesting ASH meeting, and this evening we're going to talk about some of the interesting data that's been presented at this year's meeting regarding acute leukemia, both AML and ALL. So joining me for that discussion is Dr. Farhad Ravandi, Professor of Medicine and Chief of the Section of Developmental Therapeutics at MD Anderson. Farhad, thanks so much for being with us.
Thank you very much. It's a pleasure to be here to talk about some of the more relevant abstracts in acute leukemias. I am certainly also surprised by the weather in New Orleans. I think we were all taken aback a little bit, but we have really enjoyed a fantastic meeting.
The big cold spell just swept down from Canada and hit everybody, even New Orleans. So there's been some interesting presentations, and I want to begin by talking a little bit about frontline induction regimens. A couple years ago, there was the big phase 3 trial of the 7-3 regimen with daunorubicin 45 versus 90, and the 90 milligram per meter squared daily for 3 days was significantly better. And this year, the French took a retrospective look at their data, looking at 60 versus 90, since 60 is much more commonly used than 45 to begin with. And this was not a randomized study, but this was just a look back at their population of patients, how the group that got 60 did compared to the more recent group that was getting 90. So what did they find?
So as you said, the ECOG 1900 study was an important study because it showed that a higher dose of daunorubicin can be safely be given to younger patients with AML, and it can be associated with better responses, at least for the less or more favorable groups of patients. There was not a significant advantage for people with adverse cytogenetics, for example, or with FLT3 mutation in that study. But again, it was an important study. And one of the biggest limitations of that study was, as you said, it compared daunorubicin 90 to daunorubicin 45. Now, the abstract that was presented by the French group, this ASH meeting, as you mentioned, is a retrospective study and not a randomized comparison. And if I remember correctly, they gave the higher dose of daunorubicin from about 2010 onwards, and then they compared it to their patients, again, younger patients who had received the 60 milligrams of daunorubicin. And they did not show any significant difference in essentially all aspects between the two groups of patients. So that raises the question that yes, a higher dose of daunorubicin than 45 milligrams is important in younger AML patients, but does it have to be 90, and can we just get away with 60, and perhaps to avoid any increased toxicity by the addition of the 30 milligrams?
I think that's really interesting, because you worry about the added toxicity with a large dose like 90. Well, there have been a couple other presentations at this year's meeting looking again at more favorable prognosis AML patients, and specifically the core binding factor AMLs with the T821 or the inversion 16 AML. Some of those patients don't do as well as some of the others, and the ones that appear to have KIT mutations or KIT overexpression seem to have a more worrisome prognosis. And there was a trial looking at the addition of dasatinib, a KIT and SARC inhibitor, to frontline therapy. Does this seem to be beneficial?
So as you mentioned, the CALGB group, as well as some of the European groups, have demonstrated that about up to 25% of core binding factor leukemia patients have mutated KIT, and this is, in many studies, have been associated with an adverse outcome. Dasatinib is a very potent KIT inhibitor, and has been combined with chemotherapy in other diseases, for example, in Philadelphia positive ALL. So it makes sense to see if the addition of dasatinib will benefit these patients, particularly the KIT mutated patients. As you also mentioned, apart from the mutated KIT patients, there is a subgroup that has overexpression of KIT, which is also going to be potentially susceptible to activity of dasatinib. So this was essentially I would call it a feasibility study. They did screen a fair number of patients, and I think they found about 60 patients with core binding factor leukemias. And one of the major things they showed is the feasibility of doing the testing and looking for KIT mutations in this population. And then they added dasatinib about 100 milligrams daily from about day 8 to day 24. One might not have the exact number of days. And again, they showed feasibility. There was no excess toxicity, and their response rate was quite high, and shows that there is a potential for that. Obviously, this is a phase 2 study, and as we will discuss in the next abstracts, there are competitors like CD33 directed antibodies that could also benefit the outcome of these patients.
Right. And the MRC or NCRI group from the United Kingdom, they look back at their core binding factor leukemias over the last 25 years and noted that there has been a progressive improvement in their outcome, and tried to establish what it was about, their various trials and how things progressed and what factors led to the improvement, and what did they conclude?
So the MRC group, this whole area has been subject of intense debate over the last several years actually. Starting with one MRC trial, the MRC 15, where they added a small dose of gemtuzumab, and I have to stress this is only 3 milligrams per meter squared of gemtuzumab on day 1 of induction chemotherapy to patients with AML. And they clearly demonstrated in their paper that's published by Alan Burnett in JCO that this strategy benefited significantly the patients with favorable risk cytogenetics, and also about 70% of patients with intermediate risk cytogenetics.
So the FLT3 ITDs did not do well with it, but many of the other intermediates did.
They didn't look at that in that original study. And then following that, there were actually other studies, including a plenary presentation last year or 2 years ago at ASH by the French group, where again they showed a fractionated dosing of gemtuzumab given on days 1, 3, and 5, if I remember correctly, of their traditional Ara-C and anthracycline-based chemotherapy in patients between 50 and 70, again led to an improvement in survival. And again, the benefit was seen mainly in the more favorable and intermediate risk group. So this study at ASH, they, as you mentioned, look back at their data for core binding factor leukemias in the MRC database and try to identify what was it that has led to the significant improvement that they have seen. And for example, in their early studies, they did transplant in first remission for all the eligible patients. And they went through a number of covariates. And the most important factor was the addition of gemtuzumab ozogamicin on multivariate analysis was the most statistically most significant factor in improving the outcome of these patients. So again, this was another study that shows that this agent can be a very important agent, at least in the core binding factor leukemias, but also perhaps in a proportion of intermediate risk AML patients.
And did they find that high-dose Ara-C consolidation was a significant factor also in those patients?
Strangely enough, that did not add to the.
That's
Well,
interesting.
they did show that high-dose RC, as compared to a combination chemotherapy, was beneficial, but the high-dose RC was associated with the reduced risk of relapse, and gemtuzumab given with the consolidation did not affect the outcome. It was for some reason, and they could not explain, that only the gemtuzumab given in induction was important.
Well, it seems like over the last few years at ASH, there have been a lot of presentations and a lot of discussion about gemtuzumab ozogamicin, and it had been on the market originally and then was voluntarily removed because it didn't show a definite survival advantage in some of the trials, but there was a question about the dose, 3 versus 6 milligrams per meter squared, and I get the impression that it really does make a difference if it's given with induction, that there's a much lower relapse rate, but there's always been some concern about early treatment-related mortality also in certain groups.
Correct. The study that actually led to the withdrawal of gemtuzumab was the SWOG trial, and in that study they used 6 milligrams per meter square of gemtuzumab, again in a randomized fashion, in addition to RC and anthracycline chemotherapy. And in that study they did have a higher induction mortality in the patients who did receive gemtuzumab. Now, the higher induction mortality was in the order of about 5%, which is not dramatic, and it's not significantly more than historical data. In fact, one would say 5% is actually quite a reasonable induction mortality. But in their control arm, they had a remarkably low induction mortality of about 1.5%. So clearly that was the issue with that. But interestingly, even in that study, when they looked at in a retrospective, unplanned way, among the more favorable patients, more favorable cytogenetic patients, there was an advantage in survival for addition of gemtuzumab. Now, as you mentioned, it's interesting to talk about gemtuzumab, but the drug is not available.
Not available.
So, but I would say that there are other, say, the CD33 monoclonal antibodies in development, and in this year's ASH, we did see some initial early data on a couple of those, mainly in vitro data. For example, Amgen has an agent which is a BiTE antibody that directs T cells towards CD3 expressing leukemic cells in a way similar to blinatumomab. And Seattle Genetics has an agent which is a CD33 antibody linked to another toxin.
Antibody drug conjugate.
Another antibody immunoconjugate. And so potentially those agents, and they could be even more effective agents, they could find a way to this arena. And the question of gemtuzumab is still not settled, and it is possible that it will come back to the market in one way or another.
We'll just have to wait and see. All right, good. Well, we're going to take a break, and we're going to come back and talk about some of the novel agents that have also been discussed here at ASH. Thanks so much.